Good evening, everybody. I'm Dr. Chandrasekhar Patil from Sri Sai Cardiac Center, Kolhapur. I'll be presenting proximal flow limiting dissection and distal undilatable lesion caught between Deville and Deep Blue Sea. Our patient was 58 years male. He was diabetic for 15 years. He was obese with a body mass index of 38. He had interval myocardial infarction. He has received tenecteplase recently. His echo was showing ejection fraction of 40%. His angiography was showing 3-vessel disease with syntax score of 32. His syntax 2020 score was showing 10 years PCI mortality of 16.5% and 10 years CABG mortality of 10.9% with a mortality advantage of more than 5% with CABG. However, patient refused surgery. So the plan was to do culprit vessel LAD angioplasty followed by staged PCI to circumflex and RCA. Now, this is his baseline angiogram showing a proximal LAD thrombotic calcified lesion, and there is a mid LAD 70% lesion with two diagonals arising from it. Now, if you see during right coronary injection, the LAD calcification is seen well. In right coronary artery, there is a mid RCA lesion followed by a proximal PDA lesion. Now, the plan was to do a provisional rotational atherectomy in view of recent STEMI. We had taken the right femoral approach. Left main was engaged with 7 French EBU3. The lesion was crossed with cyan blue wire, and the lesion was dilated with 2.5 by 15 non-compliant acute balloon. The proximal lesion yielded at 10 atmosphere. However, there was significant dog boning effect in the mid-LAD lesion at 12 atmosphere. This was the angiogram post-balloon. It was showing proximal spiral dissection and mid-LAD unyielding lesion, and there was distal TIMI2 flow. Now we downgraded the balloon. We downsized the balloon. We started with 2.25 millimeter by 15 millimeter NC balloon, again AccuForce at 24 atmosphere. However, the lesion was not yielding. So we changed to Scoreflex balloon 2.5 by 15, and we went up to 12 atmosphere. However, the result was the same. It was unyielding lesion. So at this point of time, the angiography was showing proximal LAD spiral dissection, mid LAD unyielding lesion, and there was distal TIMI1 flow. At this point of time, patient started getting chest pain. There was significant ST elevation. So we tried to cross the lesion with 5 French IVUS to see what is happening. So OptiCross was not crossing the lesion. So at this point of time, we had few options. The first option was to use guide extension catheter past dissection and do a rota through guide extension catheter. However, the patient was unstable and this approach would have taken significant time. The second approach was to stent proximal lesion and do a rota distally. However, in this approach, there was a risk of burr entrampment. The third option was emergency CABG, to stent the proximal lesion to temporarily improve the distal flow and send the patient to CABG. We opted for the last fourth option, that was a cautious rotablation. However, there was a fear of burr wrapping in the flap, increasing the dissection or maybe resulting perforation. So we started with 1.25 millimeter burr. We started with a low speed of 140,000 rotations per minute. We started very cautiously with pacing movement and intermittent contrast injection to see the complication early. However, the burr crossed in the second pass. So at this point of time, we kept the rota wire as it is, if in case upgrading or the burr upsizing is required. And the cyan blue was crossed distally. However, there was distal TIMI0 flow. The mid-LAD lesion was yielded with 2.25 by 15 millimeter non-compliant balloon at 10 atmospheres. So we stented the mid-LAD lesion with Zions prime 2.25 by 15 millimeter balloon at nominal pressure. There wasn't any distal flow, so we placed the stent according to the calcium landmarks. The no flow persisted in spite of multiple vasodilator boluses. With the help of the same stent balloon, we measured the proximal lesion length and we stented the proximal lesion by means of 2.75 by 28 millimeter Zions prime stent. Now, at this point of time, after stenting, there was TME zero flow distally. We tried with vasodilators injections through the guide catheter. However, it failed, and we then shifted to perforated balloon approach. Now, this is our stepwise algorithm for no reflow. We usually give guide injection by means of 1 microgram per kg of sodium nitroprusside. We usually give 2 boluses, and if hypotension occurs, then we give phenylephrine 50 to 100 microgram IV. The second strategy or the second step will be to use perforated balloon. It is usually a 2 by 15 millimeter semi-compliant balloon. The 4 punctures are made by means of 26 gauge needle, 600 microgram of adenosine, along with 2 microgram per kg of sodium nitroprusside, and tirofiban is taken as weight divided by 5 ml. And this all mixture is taken into an inflation device, and it is given through perforated balloon slowly over 2 minutes. Now, these dosages are higher as compared to the guide injections. However, they are safe as they are spread over 2 minutes rather than an instantaneous injection. So this is our personal experience. And as a last strategy, we use adrenaline 50 to 200 microgram boluses, which is a very strong vasodilator. And in very rare circumstances, when the thrombotic burden is very high, then thrombolytics can be used. So by giving distally vasodilator cocktail by means of a perforated balloon, we got distal TME3 flow. We had done post-dilatation by 3 by 15 non-compliant balloon proximally and 2.5 by 15 millimeter balloon, non-compliant balloon distally. And we got this result. This is a final result. Patient was pain-free. There was distal TME3 flow. And this was a satisfactory result. In view of a lot of procedural time and significant dye, we plan to do circumflex and the right coronary artery at second stage, maybe after 4 weeks. So to conclude, intracoronary imaging in severe calcification prevents rota regret. In our patient, we thought that the calcium is not heavy, so we tried with a provisional rota ablation. Spiral coronary dissection is absolute contraindication in addition to thrombus for rotational atherectomy. Smallest possible burr size, slowest possible speed, cautious packing movements of the burr, and intermittent contrast injection to detect any complication is prerequisite for rotablation in this scenario. No reflow in recent STEMI requires stepwise uptitration of vasodilators and antithrombotics. Perforated balloon is the best option for delivery of vasodilators in this situation. Intravascular lithotripsy, if available 24 by 7, is a safer answer for this kind of a problem. However, in our center, it is on-call availability of this option led to rotablation. Thank you very much for your kind attention.
Thank you. I think you did a very courageous procedure choosing rotablation, but possibly because you didn't have many other options. So you couldn't sort of do much. And ultimately, I think the result was lucky that you could establish flow. And I think your perforated balloon technique really worked. So it's something like that perfusion catheter. And now because they have gone out of market, then we have to deploy these homemade remedies. Yes, but I mean, perhaps, I mean, imaging after you have done the final count, final angio, that would have reassured you. So was that possible? Imaging after the final angiogram?
No, sir. Actually, it was a significant time. The procedure took a significant time. So we did not do, and the result was reasonably satisfactory. So we did not do any.
Yeah, you are right. Angiographically, it looked, but I mean, once we have gone through such a difficult time period and such a sort of stormy period, so perhaps we could have, but that's okay. I mean,
excellent case.
Because then it would have reassured us that nothing much is left there to cause a repeat trouble. What do you think, Dr. Bang?
I think it's excellent case, and in the circumstances how he managed is amazing. It's wonderful. I give him full credit for managing that case so well in limited resources. Excellent.
One quick
Excellent
question.
presentation.
How did you exchange the Siam glue to a rota wire? Did you use a microcatheter or how did you go? Because you already have proximal dissection.
No, we exchanged it to a microcatheter.
Right.
It was a caravel.
Very good.
Very good. Very well done.
Excellent case. Congratulations.
Can we go to the